pleasure that I'd like to introduce Chris Barton, who has both an MSW and is also a licensed clinical social worker. She is the Director of Integrated Systems of Care and Network Innovation at Horizon Blue Cross Blue Shield of New Jersey. She has decades of experience in New Jersey substance use disorder treatment and nonprofit social service systems. So really comes from the social service sector of the healthcare, specifically behavioral healthcare world, and has an interesting perspective on that. Also now working for a large and dominant insurer in the state of New Jersey. Previous to this position, she was the executive director at the Catholic Family and Community Services of Paterson, New Jersey. She has led the system of care, which is the ISC, for Horizon through a successful pilot that she's going to be describing to us, and is now overseeing statewide implementation of that program. So we're getting a chance to hear about some of the theory and then obviously the experience with implementation of a program. So with that, as you can see, she's already shared her screen, and I'm going to hand over the mic to Chris.
Thank you so much, and thank you for the invitation to join you all today to talk about integrated care. I wanted to add to Lisa's introduction that one of the reasons that I was hired at Horizon was because my primary language is provider speak as opposed to insurance plan speak, and Horizon was very interested in making sure that the voice of the providers and the experience of provider practitioners was included in the BH team. So I'm going to walk you through Horizon's Blue Cross Blue Shield's journey toward integrated care from the macro system perspective on through the Integrated System of Care program, the ISC. And along the way, I'll give you sort of an overview of that journey, our foundational principles, and how we've addressed integration from a product continuum perspective. And then I'm going to dive a little bit deeper into the integrated system of care. I'm very casual in my presentation style, so feel free to raise your questions in the chat and we can talk about them as we go along. Because I live in New Jersey, I tend to speak fast. If I get going too fast, don't hesitate to raise a hand and let me know to slow down just a little bit. So with that, let me tell you a little bit about our timeline over these last couple of years. By way of background, you should know that until 2019, Horizon had contracted with a vendor to manage our behavioral health services. But true integration of physical and behavioral health was really the catalyst behind Blue Cross Blue Shield's decision to end its carved out vendor relationship for behavioral health and ultimately to bring behavioral health services in-house for the first time in our company's 80-year history. Horizon's behavioral health team was born about 4 years ago when Horizon executives made the decision to hire my boss, Suzanne Kunis, who's the Vice President of Behavioral Health, to execute this vision. This chart is really a timeline of all that has been accomplished in these 4 years. Beginning in 2019, the then 2-member behavioral health team began putting together a strategy for integrated care. And that included things like piloting collaborative care models and peer support programs that were embedded in hospital ER departments, bringing behavioral health to the medical profession. Also developing value-based care episodes for behavioral health, focusing on anxiety and substance use disorder specifically. And then the very, very early planning and model development for what would become the integrated system of care. That was back in 2018. In 2019, our efforts evolved and included planning the transition to insourced behavioral health services from the contracted vendor. We also began developing and formalizing a product continuum that would address behavioral health needs at all stages of a severity continuum. We were also working on developing a strategy to evaluate performance and implement value-based programs for behavioral health. And we started implementing a pilot project for the integrated system of care in July of 2019. Late in 2019 and early in 2020, we're all about insourcing our behavioral health business. By the end of December 2019, we had the government business, Medicaid business in-house, and then in 2020, we brought in the commercial business. The rest of 2020 was focused on completing the pilot project for the integrated system of care and implementing our statewide expansion. We went from 1 county to 5. We just launched an RFP for another 7 counties, and we'll have the whole state in by the end of the year. And then all along the way, we've talked about continuing to grow our product continuum, and I'll talk more about that in just a minute. But these are our foundations of integrated care. There are really 3 main themes in our approach to integrated care at Horizon Blue Cross Blue Shield of New Jersey. The first is completing the insourcing of behavioral health services. Horizon recognized that it was ineffective to manage physical health without also managing behavioral health for our members, and we began an almost 2-year process of terminating our vendor contract for outsourced behavioral health. It was formerly contracted with Magellan, but right at the beginning of the transition was contracted with Beacon Health Options. And so we executed what we call a lift and drop. We took all of the business out and brought it inside. That included hiring about 200 staff and developing all of the systems and processes that had been outsourced for decades. It was really building a new unit within Horizon Blue Cross Blue Shield of New Jersey. Again, all of the government business, Medicaid, was insourced in December, and the commercial business came in at the end of March 2020. This actually happened 2 weeks after quarantine began, and it was executed virtually. I'm still in awe of the people that made that happen, but we were training new staff and really distributing even equipment so that people could begin their work from home all while we're trying to lift and drop this new venture. And so behavioral health is officially 1 year old now at Horizon, and really, I have to say, MMA is doing really well in terms of continuing to refine our systems and grow our products. And so the second piece is really about the continuum of resources to meet our members' care needs, whether they're very mild to moderate behavioral health concerns, all the way up to severe conditions that are life-altering and impairing. Horizon has resources to meet all of those needs, and I'll talk with you specifically about those in just a second. The third piece of our foundation to integrated care is the integrated system of care, which is a special program specifically for our members who have serious mental illness and substance use disorder. This is a population that has very complex care needs and often have undiagnosed or diagnosed but untreated medical conditions that may lead to shorter life expectancy. Through the ISC, a behavioral health provider is sort of quarterbacking the member's care to address physical health, behavioral health, and social needs. And I'll talk about that program in just a little bit more detail. But first, let me show you our product continuum. So let me orient you to this slide a bit. Across the top, you'll see a continuum line that goes from low to high, and underneath that continuum are sort of the evolution of conditions from preventative and whole health models all the way up to serious mental illness. The lower you are on the severity spectrum, the more self-directed your care is, while on the higher end of the spectrum, the care needs tend to require more structured programming and services. At the low end, we have preventative care and whole health interventions. These are things like website tools, webinars, training, self-assessments, and other digital tools that are focused on general well-being and mindfulness and meditation. When you move up into the mild to moderate needs, then we're talking about, again, self-directed but computerized cognitive behavioral therapy programs, something that's available anytime, anywhere at the click of an app. Moving into the rising risk category, we're talking more about virtual therapy and coaching programs. Telehealth support has become big this past year, as the other presenters have addressed, and developing capacity within primary care practices and physical health networks to deliver deliver behavioral health care within their 4 walls. So empowering our our medical specialists to address behavioral health needs as well as medical needs. And then as you move on into the substance use disorder and serious mental illness, these again are areas that require more structured interventions, where you see medication-assisted treatment, important to address alcohol use and opioid use disorders. The integrated system of care, which is specifically for clients with substance use disorder and serious mental illness, falls into this category as well. And then we've also developed peer support programs to help folks who have substance use disorder specifically. We're going to be growing this over the next year to help address mental health conditions as well. So we look at behavioral health on a continuum from the low severity to the high severity, and we're trying to develop programming that meets the members' needs where they are, not fit them into a box of any sort. So these resources are available to our members. They're also available for our physicians to refer their members, refer their patients to these services when they're available through their covered health insurance plan. And then moving on to what I like to consider our crown jewel, because it's kind of my baby, is the integrated system of care. So the integrated system of care addresses the physical health, behavioral health, and social determinants of health needs for our members, again, with serious mental illness and substance use disorder. The ISC is a part of the core offerings for the Horizon Blue Cross Blue Shield of New Jersey. So any of our members who are fully insured in our commercial book of business, fully insured, and the ASO groups all have this integrated system of care program available to them. The ISC connects physical health providers, behavioral health providers, and social determinants of health providers on a regional basis to work collaboratively to help members with these conditions. Now, the population with serious mental illness and substance use isn't a very large portion of our membership at Horizon. It's really only about 5% of our membership. But these conditions are very, very complex. Members with these conditions tend to be frequent users of hospitals and ER visits. They tend to use higher levels of care, and in some cases, they tend to go out of state to residential treatment programs and detoxes, which leads to a whole host of other problems. But these hospital ER visits, higher level of BH care, they all drive up the cost of care. And in many cases, they don't do much to help these members address their behavioral health needs. Here in New Jersey, the typical per member per month cost for a member with serious mental illness or substance use disorder is in the neighborhood of about $1,500 per month. And so this is a population that draws a lot of attention, particularly in value-based arrangements where behavioral health risk is shared. Then we're looking at developing programs that are going to reduce those medical costs. We believe that helping these members access high quality and comprehensive care will ultimately put them on the path to recovery and will reduce the utilization that's driving up the cost of care. But there are many barriers to high quality integrated care. And I'm sure these have been addressed several times in this meeting today. There is stigma related to substance use and mental health disorder. There are fragmented service delivery systems, and even siloed care where traditionally mental health and behavioral health have been delivered separately and with very little crossover between the two. Heck, even in behavioral health, their mental health was treated separately from substance use disorder, and never the twain shall meet, sort of. It wasn't until 10 years ago or 15 years ago that we began talking about an integrated behavioral health care where you could treat both mental health and substance use disorders within the same setting. And so drawing on broad base of evidence-based practices, including the behavioral health homes and the certified community behavioral health clinics, and some of the work that's been done with the Medicaid population and research and demonstration projects, we sort of reimagined the delivery system for clients with SMI and SUD, and we developed this virtually integrated community of physical health, behavioral health, and social determinants of health providers. And we've added what we call an integrator. Think of them as a quarterback to help coordinate care on behalf of the member so that members don't have to navigate systems on their own. They have somebody advocating for them and helping them to get through it. Okay, this is sort of a picture of our integrated system of care. Remember, this is a model for serious mental illness and substance use disorder. I think it's sort of a step further along a continuum of severity than the previous presenters were talking about clients with mild to moderate mental health and sometimes substance use disorders. But what we learned was that many of our clients with SMI and SUD don't have primary care relationships. Or if they do have a primary care relationship, they're very compartmentalized in what they talk with that primary care provider about, and often it doesn't include their mental illness and substance use disorder. So some of the reasons that we have developed, again, we talked about the fact that it was a very high acuity group. There's a very, very high rate of recidivism and a frequency of using high cost services. But also, again, many of these members have undiagnosed or diagnosed but untreated chronic medical conditions that are contributing to shorter life expectancies. And we know that there are systemic barriers, including stigma, including fragmented care for clients with serious mental illness and substance use disorder. We thought that these were barriers that were systemic but addressable, and that by addressing them, we could impact outcomes for our members. And I think you'll see that we did that. One of the key strategies in addressing accessibility was to make the behavioral health provider the center of care. So many models of integrated care have been built around physical health providers, and there's an appropriate place for that. But at least, as I said, for our clients with SMI and SUD, we didn't find that those primary care relationships existed or weren't expansive enough for the members to be talking about their mental health and substance use concerns with their primary practitioners. So we moved the center of care from the physical health provider to the behavioral health provider. We felt that the behavioral health provider was going to be more experienced in working with clients with SMI and SUD, and that they were going to have the staff and resources available to meet the demands of this population. It's a population that has frequent visits, frequent inquiries, and they often have a whole host of non-medical and non-behavioral health needs, frankly. They're often food insecurities, housing insecurities, transportation concerns. All of those things impede the client's access to care. And so we located the ISC in the Behavioral Health Center. Again, this is a virtual collaborative care relationship. It is not co-located, but this relationship between the primary care physicians and the ISC behavioral health provider is bidirectional. So primary care practitioners may refer into the behavioral health center clients who they identify as needing ISC care, clients with serious mental illness or substance use disorder. As well, the ISC behavioral health provider can refer to a primary care practice who is known to be friendly to the population that we're serving. I think if you think of this population as having its own unique culture, there's a cultural competence that comes with working with clients with SMI and SUD. And so we wanted to establish relationships with primary care practices that were friendly to this population as well. And so there's this back and forth relationship between the primary care physicians and the outpatient behavioral health center, where PCPs are referring to the behavioral health center. The ISC behavioral health center is referring to primary care practices. They're sharing information back and forth about the client. The ISC behavioral health provider is monitoring clients on a monthly basis and reporting to the primary care practice about what's going on, participating in shared decision-making about next steps for the client, and addressing an integrated care plan. In the meantime, The behavioral health center is also delivering behavioral health treatment. They could be treating a client either just therapy, they could be seeing a behavioral health prescriber, they could be in one of the structured intensive outpatient, partial hospitalization, or partial care programs that the behavioral health center runs. I talked about the fact that they're conducting monthly wellness checks. Our care navigators at the integrated system of care behavioral health provider are oftentimes taking clients to their specialist appointments. We've seen members just kind of paralyzed with not knowing what to do next. They see their primary care physician, they talk with the nurse practitioner, and they are given a referral, let's say for a diagnostic test or to see a specialist, and really don't have the wherewithal to make that happen. So our care coordinator at the behavioral health center is walking alongside them, sometimes walking with them into the provider, getting firsthand information about follow-ups and outcomes of testing, and helping to facilitate that for the member as well as for the primary care practitioner. And then the last piece is that they are addressing social needs, supporting the member in, again, obtaining transportation or many cases they're providing transportation or they're using Uber Health. They are tapping into their existing resources to meet social determinants of health needs. In some cases, the behavioral health practitioners have food pantries and they're supporting members' food insecurities in that way. They're connected with local housing authorities and are helping clients to get into low-cost housing. They're also tapped into workforce development, so they're helping clients to develop the resources that they need to find and get a new job. Okay, let me share with you a couple of some of the outcomes from the Behavioral Health Project. I mentioned to you that Horizon conducted a pilot project for the integrated system of care between July 2019 and July 2020. Our integrated system of care partner, we chose one trusted behavioral health partner in Monmouth County, New Jersey, and one trusted behavioral health system in Monmouth County, New Jersey, and together they enrolled over 500 members in that one-year period. During the pilot project, we used a standardized outcomes monitoring tool called the GPRA, the Government Performance and Results Act, which is a tool that many demonstrations projects use and was already existing in the behavioral health provider at that time. It was administered at admission, 3, 6, and 9 months post-admissions. And then we compared those responses, and we found that over a 9-month period, the members that were enrolled in the ISC had an 80% reduction in hospital visits. They had a 75% reduction in ER visits. They reduced their alcohol consumption by 65% and their illegal drug use by 90%. And they reported a 72% improvement in quality of life indicators. We validated this self-report with Horizon's claims data and confirmed the reductions in ER visits and hospital stays. And actually, in some cases, they were even a little bit higher than the self-report. But ultimately, all of this contributed to reductions in total cost of care. And I don't want to discount this last, change the screen. I don't want to discount this last quality of life indicator. This is really critical for clients who are experience substance use disorder and serious mental illness. For many of them, their lives have been greatly impacted by their disease state. And they've lost family, they've lost housing, they've lost all of the things that help to get them grounded. If they don't have a place to put their head at night, if they don't have food in their stomachs, it's hard for them to make good choices about getting and staying in recovery and managing their illness. So that's an important piece, a critical piece of the ISC. And I wanted to just share a couple of patient journeys with you to illustrate how the ISC works. I'm going to orient you to this upper left-hand corner over here. This is the ISC ecosystem. The pink represents physical health, the green represents behavioral health, and the gray represents social determinants of health. I'm going to give you some background information about the client, but then this is their roadmap, their journey. The pink, again, references physical health, the green is behavioral health, and the gray is social determinants of health. So Darlene sought treatment herself at CPC, which is our behavioral health provider, and based on her assessment was assigned to the integrated system of care. She had a long history of bipolar disorder too, and had been offered meds for quite a long time. And she was using alcohol to self-medicate. Darlene also had some chronic medical conditions, many of which were related to her chronic alcohol use and smoking, including hypertension, IBS, and GERD. Darlene had not seen a primary care physician in some time, so CPC connected her with a PCP practice that was familiar to the ISC and that welcomed patients with behavioral health conditions. The PCP and the CPC nurse practitioner worked closely to manage and monitor Darlene's physical health conditions. CPC also did a complete evaluation and started Darlene on both Vivitrol to address her acute alcohol use disorder and medication to treat her bipolar disorder. Darlene was engaged with her therapist and case manager at CPC, and she made good progress, but experienced a relapse several months into her treatment. She re-engaged immediately and was able to get back on track. Now Darlene has been abstinent for a year. Her medical conditions have improved significantly. She got her job back and has reestablished a relationship with her son. Her mood disorder, her mood is great, and she's beginning to gain some financial stability. And she and her counselor are starting to work on her next goal, which would be to quit smoking. The next case is Mario. Mario was referred to the ISC in January 2020 through one of our PCP practices. He had a long history of alcohol use disorder and some physical health problems related to his drinking. Mario had just been hospitalized for a GI bleed related to his drinking and also had elevated liver enzymes, hypertension, and high cholesterol. The PCP practice worked with the patient and CPC's nurse practitioner to get the client set up with medication to address the most acute medical conditions, and the nurse monitored these monthly. Initially, Mario refused to stop drinking, so the behavioral health intervention was really a harm reduction intervention. Ultimately, though, over time with motivational enhancement intervention, Mario eventually made the decision to stop drinking and agreed to use Vivitrol to help him do that. Vivitrol has been very effective for Mario. He's coming up on 8 months sober and still using Vivitrol. He's attending therapy and working with his case manager on follow-up medical appointments. All in all, he is doing very, very well. This is all very promising. It's all very encouraging. We can see anecdotally as well as in the data that the ISC model is making an impact for clients with serious mental illness and substance use disorder. And so by the end of 2021, we expect to have the ISC program in all 21 counties in New Jersey and to continue to grow, not just in breadth, but in depth in those counties and really orienting our physical health partners to what's available in the ISC, how it can complement their existing embedded behavioral health practices, as well as offset their total medical expense. And that's the Horizon's integrated care.
Thank you, Chris. Great presentation and really a lot of detail that's incredibly helpful. There was a specific question that came from one of our colleagues, Victor Pincus, specifically wanted to know what kind of tool you were using as to stratify risk, if there was a standard tool or if you had a, what you're using to get some sense of where patients fall on the spectrum of need.
We aren't using any specific tool at the plan, at least. I think different providers are using different assessment tools, everything from PHQ-9s to GAD-7s to even crisis risk assessments. There are tons of tools out there. We're not prescriptive about what needs to be done and how to assess risk. Okay. For the integrated system of care, there's a whole list of diagnoses that qualify for the integrated system of care because we're trying to stay true to the model, right? But typically clients with serious mental illness are those that have significant impairments and who are frequent utilizers of high-cost services. So we've included bipolar disorder, schizophrenia, schizoaffective disorder, even personality disorders. So we try to be as inclusive as possible with the criteria, but knowing that we want to focus on the clients with more serious impairments that are not well treated in collaborative care practices.
Standard. Okay, great.
I hope that helps.
Thank you. Deb Hurwitz, did you want to add to that discussion, or looks like you had a comment in relation to that?
Oh, I was thinking that maybe there was a question around the GIPRA and how you use the GIPRA.
Oh, okay. So the GIPRA is, it's been used in demonstration projects. I think it was one of the presidents, Bush maybe, that introduced the GIPRA as an outcome monitoring tool for federal demonstration projects. Our partner for the pilot project was one of the CCBHCs, which is a SAMHSA funded demonstration project, and they had that system in place right now. It's not a screening tool, so it won't tell us what the risk is, but it gives us a lot of information about where the client was and where they are at the longitudinal administration of the survey.
Yeah, we've been using it for our SBIRT program, and from a primary care perspective, it's something like 25 pages long. So, I mean, it was really onerous in terms of implementing it within primary care as a regular reporting tool. But, you know, we have done it, and we are doing it, you know, not deep in primary care, but in other areas where we have to, because it's required for, you know, federal compliance with the grant. But it's quite a thing.
Well, I think when you're using it in the context of a demonstration project or as an evaluation tool, it makes a lot of sense, right? Because they want that level of detail, and the purpose is evaluation. But you can't use it on an ongoing basis in a therapy setting. It just we've switched to another instrument.
No, it's not. Yeah. But, you know, even to get primary care to participate in some of, like, you know, for example, SBIRT screening, when they looked at the tool, they bowed out. So we had to find other settings. We had to find other settings to, you know, do the SBIRT screening that was going to be funded, and that tool was going to be required. But, you know, a number of the practices have, you know, at least in Rhode Island, they've worked, I think, through HRSA to implement SBIRT, and that wasn't required, and they've done just fine. Just, you know, well.
Yeah, you have to ask yourself if you really need all of that information, or if there's another way to capture it. I agree.
It's always complicated. Well, speaking of information sharing, I have a question from Dr. Shanka in Ohio. And his question is if you've run into barriers with what information behavioral health can share with the primary care practices. And this is around protected health information and a specific question around whether there's patient consent required.
We did use patient consents. So HIPAA sharing of information, you know, we all know about. There's the additional requirement of 42 CFR Part 2 for substance use disorders. So we did consent each of the clients to share information with their primary care providers. We also had the added benefit of Horizon has a proprietary HIE, Health Information Exchange. All of our strategic alliance partners and major health systems report into HealthSphere, and our behavioral health provider was able to view HealthSphere and get just a wealth of medical information that we behavioral health providers have never really had access to. So they had a look into that history, and they've used that very well to help manage information, as well as even confront inaccuracies, or inaccuracies isn't the right word, but it's going to escape me for a minute. Differing history that the patient is reporting. So we had a client just a week ago who said, no, I don't have any opioid use disorder. But when they logged into HealthSphere, saw that 2 weeks ago had been hospitalized for an opioid overdose. So it becomes collateral information for the social worker who's working in the ISE to talk with the patient about, you know, how to use this information and how to integrate it into their care plan.
Thank you. So we had a specific question from one of our insurer colleagues and asking if you implemented value-based performance measures for the ISE, and if so, what measures did you use?
We do have a value-based contract with our new ISC partners. The measures that we are looking at are priority access following hospitalization and ER visits, MAT engagement, primary care physician engagement, and readmission to hospitals, ERs, and behavioral health higher levels of care. So our providers, we've actually converted the providers to a case rate rather than fee for service. So they're on a case rate that's driven by the level of intensity of services that they provide, and then annually they'll get a performance incentive.
Thank you. And a point of clarification was just requested from Dr. Gibson that the ISC social workers are doing care management versus mental health therapy. So what roles are they playing?
The ISC provider is doing both. So the ISC provider can, three things really. They can be an APN care coordinator who's working directly with the primary care practice. There are behavioral health clinicians who are delivering therapy, and there are case managers who are addressing everything else.
So it's 3 different people, or one person doing 3 different roles?
No, it's a provider practice, let's say, that has those 3 different roles within it.
Excellent. It's an excellent program.
Great.
It really draws on the strengths of behavioral health for the clients with higher needs. So again, I don't think there's an either or to the Rhode Island presentation and my presentation. I think that my population is just a step further along in that continuum of severity than maybe it can be treated in the collaborative care practice or the integrated behavioral health practice.
That's great. So I have actually a question around how the ISC team interfaces with housing in terms of looking, because obviously this is a population with high rates of homelessness and sort of churn in terms of their housing arrangements and how you address that.
The integrated system of care providers are I don't know if any of you are familiar with community mental health centers. They are the agencies that have been dealing with deinstitutionalization and finding people places to live for decades. So working with that provider population, they already have inroads into the, in New Jersey, we call them the continuum of care, folks who have access to housing vouchers and low-income housing and sometimes shelter vouchers if we need those, although those would be more of a last resort. But they have inroads, well-established inroads into those systems. And in some cases, some of our providers have begun leasing units on their own and renting those to participants, not just in the ISA, but in their programs. They become the leaseholder. And the landlords are happy with that because they have a secure leaseholder, and the tenants are being managed in the program.
Okay, thank you. Any other questions for Chris? Comments? Well, once again, thank you so much for an excellent presentation on a program that really is a leader. And it's really, I think I'm very pleased with the way these 3 presentations have complemented each other. because I really feel like we're looking at a spectrum of certainly geography, sort of scale, looking at, statewide work versus things that are more narrow, rural versus urban. All of these things are part of the spectrum, and your focus certainly on people who really suffer from the most severe forms of mental illness, I think is a really fascinating component that often does get carved out, as we know. So thank you. Chris, a quick question. Are you comfortable with your sharing your slides with the group, or do you need to go back internally to okay that? I'm happy to wait on that.
No, I can share these slides.
Okay, great. So that answers my final question for everyone, which is that these slides and a recording that's being made and will be pared down for each of the individual presentations will be available on the Milbank Memorial Fund website on the web page for the multi-payer primary care practice demos work. And we really are, just feel very fortunate to have the expertise and generosity of our colleagues who have shared their about so much information, rich information about the programs. Anybody else have questions or comments for today? If not, I think we can sign off a few moments early. It's been a long day for all of us, and I really thank you all for participating in this. I felt like I've learned a lot, and I hope all of you have as well.
I just want to say thank you for the opportunity, and it kind of speaks to the similarities that we have in our different locations, and there are national standards and evidence, but yet we're each trying to grow it in our own little area of the country, and in some ways having to learn ourselves how to make this work. And so seeing the best practices of other places is encouraging. So for this group to be able to exist and to share these practices is exactly where I think we need to go. And thank you for helping us be involved.
Thank you so much, Patty. Appreciate it.
And Lisa, this is Deb. Just one thing I'd love to just ask Chris Barton. Our mental health authority is the group that's sort of leading the transformation work that you've described for the, the specialty mental health sector, the community mental health centers. And I'd love to be able to share your slides with them. I think we have a call coming up in a week or so with some of those folks, and we try to keep tabs on each other while we're dealing with IBH, in primary care. They're dealing with the specialty, clinics for, the behavioral health, centers and SMI, SPMI folks. So is it possible if they were interested, would you be available or willing to have a call with them just to describe your system?
Yeah, I would love that. In fact, I always prefer that to sharing just the slides, so that I can speak to them. So yeah, definitely. Oh,
thank you. I'll mention that when we speak with them, but it's just incredible what you've done, and really hats off. Great job.
Great. Well, this is exactly why this collaborative exists, this type of interaction between people who are part of the group. So thanks everybody for illustrating that. I really appreciate it. I'm going to go tell my boss pretty soon. Thanks everyone.
Thanks everyone. Thanks.
Happy spring. Stay well. All the stuff will be up on the website within a few days, and we look forward to our next opportunity to gather together. Thank you.
Terrific. Bye. Thank you. Bye all.
Thanks.